Welcome. This video contains useful information about the Adolescent's meningococcal vaccine. It was developed for healthcare providers working at Indian Health Service, tribally run, and urban Indian healthcare facilities. My name is Dr. Jasmine Curry Thomas. I am a member of the Navajo Nation and a resident physician in family medicine. I am partnering with Native Boost to share this presentation with you today. For those of you who may not be aware, Native Boost is a project at the Northwest Portland Area Indian Health Board dedicated to sharing accurate, high-quality childhood vaccination resources with Native people and their medical providers. To access Native Boost patient education tools, you can visit www.nativehealthresources.com. Click on the Resources tab and filter resources by the Native Boost campaign. Okay, let's get started. Today, we will discuss essential information about meningococcal disease, meningococcal vaccines, and current vaccination recommendations for adolescents. I will also share useful talking points you can use when speaking with parents and caregivers. Finally, I'll offer some additional resources. Let's take a few minutes to discuss meningococcal disease. Neisseria meningitidis, or meningococcus, is a leading cause of bacterial meningitis in the U.S. In 2023, there were 438 confirmed and probable cases in the United States. Most cases occur sporadically, with only about 5% occurring as part of an outbreak. There are 12 serogroups of meningococcal disease, with the most common in the U.S. being serogroups B, C, W, and Y. B and C have historically been the most common, but since 2022, the Y serogroup has become the most common. It is not known why this shift has occurred. At this time, there is no change in vaccine or treatment recommendations because of this shift, but it may be important in the future. Rates of meningococcal infection are highest in infants less than 1 year of age, children less than 4 years, adolescents 17 to 21, and adults over 85 years. Routine meningococcal vaccination is recommended for all adolescents, which is the focus of this discussion. For those in other age groups, vaccination is only recommended for those with specific risk factors, which we will briefly discuss later on. Meningococcal disease results in infections including meningitis in 50% of infections, bloodstream infections or meningococcemia in 30% of infections, and pneumonia in about 15% of infections. Meningococcal meningitis is not readily distinguished from other causes of meningitis. Initially, patients have high fever, headache, nausea, and vomiting. Later on, neck stiffness, photophobia, and altered mental status develop. The overall mortality from meningococcal meningitis in the U.S. is about 8%. Meningococcemia is caused by meningococcus in the blood. Patients usually present with the characteristic whole body, non-blanching petechial rash. Patients are toxic appearing with high fever, myalgias, nausea, and vomiting. The majority of patients with meningococcemia also develop meningitis. Meningococcal pneumonia is clinically indistinguishable from other causes of bacterial pneumonia. The most common symptoms are fever, chills, and pleuritic chest pain. It is the most common presentation of meningococcal infection in those over 65 years. The overall mortality proportion for those with any type of invasive meningococcal infection is between 10 to 15%. Apart from age, the other risk factors for meningococcal disease, defined as any invasive meningococcal infection, include immunocompromising conditions such as complement deficiency, asplenia, and HIV infection. Immunocompromised children typically have more severe and prolonged illness. Exposure during an outbreak, occupational exposures among laboratory workers, and those who live or travel in hyperendemic areas also have higher rates of invasive infection. Exposure to overcrowding, tobacco smoke, and other viral respiratory infections may also lead to higher rates of disease. Now let's take a moment to discuss the ins and outs of the meningococcal vaccine for adolescents. There are two types of meningococcal vaccines available for use in the U.S. The first are quadrivalent conjugate vaccines, which protect against serogroups A, C, W, and Y. These are part of the routine adolescent vaccines. The second type of vaccines are serogroup B recombinant protein vaccines, which protect against serogroup B only. Serogroup B recombinant protein vaccines are recommended for use with shared decision-making rather than routine use. This is a category used by the CDC Advisory Committee on Immunization Practices when the cost and benefit of routine use may not be as strong as for other vaccines that are routinely recommended. It also has implications for insurance coverage since only immunizations recommended for routine use are guaranteed to be covered by private insurance and publicly funded vaccine programs, like the Federal Vaccines for Children program. There are two different quadrivalent vaccines available for routine vaccination in the US. Menveo or Menquadfi. A third vaccine, Menactra, was discontinued in 2023. Estimates of vaccine effectiveness within 1 year vaccination was 79%, with a range of 49 to 91%. Vaccine effectiveness decreased to about 69% 1 to 2 years after vaccination and decreased further to 61% 3 to 8 years after vaccination. Clinical studies for both quadrivalent vaccines have shown pain and erythema were common injection site effects. The most common systemic side effects reported in children included irritability and drowsiness. Common systemic side effects in adolescents and adults included myalgia, headache, and fatigue. Reported side effects were mostly mild and resolved within 3 days. Just of note that irritability here means crying that is inconsolable or prevents normal activity, and drowsiness means sleepiness that prevents normal activities. These terms are used to describe responses to vaccination in infants and young children. Post-licensure monitoring through Vaccine Adverse Event Reporting System for Menveo was published online in 2020. The report did not identify any new safety concerns or differences in the safety profile from those originally described in pre-licensure clinical trials. Post-licensure analysis of VAERS data for Menquadfi has not been conducted yet as of January 6, 2025, since it is too soon for sufficient data to accumulate. However, to date, no adverse event signals have been reported by CDC from the system. A recent review reported to the CDC Advisory Committee on Immunization Practices, or ACIP, did not identify any serious adverse events from the vaccine across 9 recent clinical trials. There are two different recombinant serogroup B vaccines available in the US, Trumenba and Bexsero. In clinical trials, the antibody response was 81 to 84% for Trumenba and 63 to 88% 1 month after the second dose of Bexsero. One study reported the duration of antibody response after 2 doses of Bexsero. After 1 month, 88% of recipients had a protective antibody response. This declined to 66% of recipients after 11 months. Clinical efficacy and population effectiveness studies are unavailable as of January 6, 2025, as it takes several years to accumulate sufficient data for meaningful analysis for these rare infections. Safety studies for both recombinant sero-B vaccines have shown pain, erythema, swelling, and induration were common injection site effects. Common systemic side effects in adolescents and young adults included headache, fatigue, myalgia, and arthralgia. Reported side effects were mostly mild and resolved within 5 days. Post-licensure monitoring through VAERS, published in 2020 and 2022, has not identified any new safety concerns for either vaccine. In 2023, a new pentavalent combination vaccine, Pembraya, was licensed combining a conjugate ACWY vaccine known as Nimenrix with Bexsero, a recombinant sero-B vaccine. Nimenrix has been used outside the U.S. since 2012, primarily for infants. Safety of the new pentavalent combination vaccine in clinical trials was similar to the individual vaccine components, with no serious adverse events or new safety concerns identified. Efficacy based on seroresponse was also equal to either vaccine alone. Now we will discuss vaccine recommendations. To ensure vaccines are safe and effective, vaccine recommendations are continuously updated based on the new information from disease surveillance systems, the Vaccine Adverse Events Reporting System, or VAERS, the Food and Drug Administration, vaccine manufacturers, and independent researchers. The CDC Advisory Committee on Immunization Practices, or ACIP, is the body that reviews this data and determines the recommendations published in the CDC immunization schedule. ACIP is a group of clinicians, researchers, public health experts, and at least one unaffiliated community member that meets at least 3 times a year. ACIP meetings are open to the public to increase transparency and public trust regarding vaccine recommendations. The CDC immunization schedule recommends use of quadrivalent meningococcal vaccine for routine vaccination of all adolescents without a contraindication beginning at ages 11 to 12 with a booster at age 16. The minimum time between two doses is 8 weeks. Keep in mind there are specific recommendations for travel or special situations for younger children that could impact adolescent dosing. Special situations for use of quadrivalent meningococcal vaccines include anatomic or functional asplenia, including sickle cell disease, HIV infection, persistent complement component deficiency, complement inhibitor, or use of a complement inhibiting medication. When Menveo is used, 1 to 4 doses should be given based on the age at first vaccination. Minimum dosing intervals are 8 to 12 weeks apart, again, depending on age. Providers should be aware of the two formulations for this vaccine, lyophilized and liquid. Both can be given to children 10 years or older, but the liquid formulation should not be used for children less than 10 years of age. When Menquadfie is used for infants or older children and adolescents with special underlying conditions or who are traveling to endemic areas, it is given as a 2-dose series at least 8 weeks apart. The minimum age for Menquadfie is 24 months. Children and adolescents at high risk may also need booster doses given 5 years after the last dose given over the age of 7. Because these situations are rare, viewers are referred to the CDC Child and Adolescent Immunization Schedule notes Special Situations tab for quadrivalent meningococcal vaccines. Shared clinical decision-making is intended to guide decisions regarding vaccination of adolescents and young adults without a contraindication between ages of 16 and 23, but preferably 16 to 18. This should include a discussion of risk of infection and duration of protection. Both vaccines are given as a 2-dose series administered 6 months apart. If less than 6 months occurs between doses, a third dose should be given at least 4 months after the second dose. As with the quadrivalent meningococcal vaccines, special situations apply for serogroup B vaccines. Individuals who are at higher risk for group B meningococcal infection should also receive primary vaccination as well as booster doses as long as they remain at elevated risk. This includes those who have anatomic or functional asplenia, persistent complement component deficiency, or use of a complement inhibiting medication, and anyone who is exposed during an outbreak or working in a microbiology laboratory. When Bexsero or Trumenba are used, make sure to administer the same brand for all doses, including booster doses. These are 3-dose series, administered 1 to 2 months apart between the first and second doses and 6 months apart between the second and third doses. There is no minimum age for use. For detailed information, viewers are referred to the CDC Child Immunization Schedule Notes section for serogroup B meningococcal vaccines. Children aged 10 years or older may receive a dose of Pembraya as an alternative to separate administration of quadrivalent and serogroup B vaccines when both vaccines will be given on the same clinic day. For age-eligible children not at increased risk of meningococcal disease, if Pembraya is used for dose 1, then Trumenba should be administered for dose 2 of the Men-B component. For age-eligible children who are at increased risk of meningococcal disease, Pembraya may be used for additional serogroup coverage of ACWY and B doses, including booster doses, if both would be given on the same clinic day and at least 6 months have elapsed since most recent Pembraya dose. Contraindications for quadrivalent meningococcal vaccines include severe allergic reaction to a vaccine component or following a prior dose of vaccine. Contraindications for Menveo also include severe allergic reactions to any diphtheria toxoid or CRM197 containing vaccine, and contraindications for Menquadfie also include severe allergic reactions to a tetanus toxoid containing vaccine. Precautions for quadrivalent meningococcal vaccines include moderate to severe acute illness with or without fever. For Menveo only, precautions include a history of preterm birth in infants younger than age 9 months. For serogroup B meningococcal vaccine, the only contraindication is severe allergic reaction to a vaccine component or following a prior dose of vaccine. Precautions include pregnancy due to lack of safety data and moderate or severe acute illness with or without fever. for Menveo, an additional precaution is latex sensitivity. For the pentavalent vaccine, Pembrya, all contraindications and precautions for both the quadrivalent and the serogroup B vaccines apply. You may have thought during this section on vaccine recommendations, wow, this is getting a little complicated. If only there was an app for that. Well, there is. The CDC Vaccine Schedule app is a great resource for meningococcal and other vaccine recommendations. It is available for download for free for both iPhone and Android phones. The app is continuously updated with the latest immunization schedules for children and adults. It also includes catch-up vaccine schedules for people who may be under-immunized, as well as the most recent information on vaccine precautions and contraindications. To recap, thus far we have discussed meningococcal disease and meningococcal vaccines, as well as current vaccine recommendations for adolescents. Now we will discuss strategies for talking with parents and caregivers about meningococcal vaccines and vaccines in general. Notably, suggested approaches and talking points are based on research conducted by Native Boost. In 2024, Native Booth conducted 11 focus groups to gather the thoughts of tribal community members and healthcare providers and clinic staff in the Pacific Northwest. In the end, we spoke to over 58 providers representing 12 tribal and 2 urban clinics and over 44 tribal community members from across the region. Through speaking with community members, we learned that they want to learn the basics about what the disease is and why vaccines are important via face-to-face conversations with trusted medical providers. Thus, when educating parents and caregivers, it is important to take time to discuss what meningococcal infection is, as well as the potential consequences of not vaccinating against it. Something to keep in mind when speaking with Native people is that it is vital to use clear and concise language and to avoid using medical or scientific jargon. During talking circles, many patients and caregivers expressed that they did not understand or relate to medical or scientific terminology. To avoid making their provider feel like they were being challenged, parents and caregivers commonly said they avoided asking questions about concepts or words that they did not understand. So, as a provider working with Native people, when you use medical or scientific jargon, you are missing an opportunity to effectively communicate valuable information to your patients. When it comes to speaking with your patients about meningococcal infection and the potential consequences of not vaccinating against it, consider saying something like this. Meningococcal infection spreads easily. It can cause permanent damage to our brain and body. Some even die. At times, people who are infected don't show any warning signs, but they can still pass it on to others. Thankfully, there are vaccines that can help protect everyone. Then consider letting parents and caregivers know just how effective meningococcal vaccines are by saying something like, I let all patients know that meningococcal shots are effective. They significantly reduce the chance your child will get sick. If they happen to get sick, which is unlikely, their illness will probably be mild. Based on Native Boost research, one of the topics Native parents and caregivers were frequently interested in was vaccine safety, particularly as it relates to Native people. To address parents and caregivers' concerns about vaccine safety, make sure to let them know that since meningococcal infection can result in serious health issues, we have been regularly vaccinating kids in the U.S. since 2005. Since the meningococcal vaccine was approved, millions of Americans have safely received the vaccine, including American Indians and Alaskan Natives. Make sure to remind your patients that serious reactions to vaccines are uncommon by saying something like, if you feel hesitant about vaccinating, keep in mind that serious reactions to vaccines, like the meningococcal vaccine, are extremely rare. You're more likely to get hit by lightning than have a severe allergic reaction to any shot. Based on Native Boost research, it is important to normalize mild vaccine side effects. Make sure to emphasize that after receiving the meningococcal vaccine, like any vaccine, children may experience mild side effects. Consider saying something like, when it comes to the meningococcal vaccine, common side effects may include fever, pain, redness, or swelling where they got the shot. Mild side effects are a good sign that your child's body is preparing to fight meningococcal infection. Within our bodies, each of us has warrior cells, also called antibodies, that stand guard and attack disease. Vaccines like the meningococcal vaccine help our warrior cells see and fight disease. For example, when we get the meningococcal vaccine, the ingredients in the vaccines tell our warrior cells how to recognize and fight against the meningococcal infection. Sometimes, when our warrior cells are preparing to be able to fight, they cause mild side effects. These side effects are not a sign of illness. They are a sign your child's body is getting prepared, if needed, to fight meningococcal infection in the future. Most mild side effects usually go away within a few days. If anything seems unusual or you are unsure, call the clinic. We can help. To summarize, thus far, we have discussed the importance of educating parents and caregivers about the basics of meningococcal infection, as well as the potential consequences of not vaccinating against it. Based on our research, we emphasize the need to use clear and concise language and avoid medical and scientific jargon. We also offered language that can be used when discussing meningococcal vaccine effectiveness and safety, and the need to normalize the experience of mild vaccine side effects. Now we will discuss strategies for sharing culturally resonant messages with parents and caregivers that center a Native perspective, something tribal community members said would encourage them to get their kids vaccinated. When asked about effective messaging around vaccination, tribal community members commonly express the desire for providers to emphasize the benefits of vaccination from both an individual and community perspective. To do so, consider reminding patients that vaccination protects their child and others in the community. Also, remind parents and caregivers of the responsibility to care for one another and for generations yet to come. Finally, make sure you present information about vaccines in a way that honors parents and caregivers' autonomy and individual sovereignty. This includes providing information about vaccines in a non-judgmental, empathetic way that affirms parents and caregivers' experiences while sharing accurate information. As medical providers, it's critical to listen to patients' concerns, take time to share basic information about vaccines, answer questions, address myths, and accept that parents and caregivers have the power to determine the right choice for their child and family. The package inserts for each vaccine are available at FDA.gov. Some of the ingredients that parents might be concerned about are shown here. Menveo and Menquadfeed both have no preservatives, adjuvants, or antibiotics. They do have small amounts of residual formaldehyde, less than 0.3 micrograms to 3 micrograms. Trumenba contains 0.25 milligrams aluminum and polysorbate 80, which aids in keeping the vaccine components in a solution. The rubber stopper contains natural latex. Bexsero contains aluminum, 1.5 milligrams, and kanamycin, which is an antibiotic. Pembraya contains 0.25 milligrams aluminum and polysorbate 80. To enhance your knowledge about meningococcal disease and other vaccine-preventable diseases, there are a few resources I'd like to share. One is the Epidemiology and Prevention of Vaccine-Preventable Diseases, also known as CDC's Pink Book. This comprehensive manual provides detailed information about vaccine-preventable diseases and all vaccines on the CDC immunization schedule. The most recent edition was published in 2021. Since then, however, there have been changes made to the schedule. To ensure you have the most up-to-date information, make sure to check the CDC 2025 Child Immunization Schedule, which can be found on the CDC's website or accessed on the CDC Vaccine Schedules app. Finally, if you would like to access culturally resonant patient education materials offered by Native Boost, visit www.nativehealthresources.com. Also, check out www.indiancountryecho.org/boost for additional trainings for medical providers working at IHS, tribally run, and urban Indian healthcare facilities. Thank you for watching this presentation. Together, we can increase the number of Native kids who are protected against meningococcal disease and other childhood illnesses.